Good morning, everyone. We'll get started with our webinar. This is a webinar presented by the Minnesota Breastfeeding Coalition in partnership with the Minnesota Department of Health program called Baby Friendly Hospital Initiative Update, what Minnesota hospitals and providers need to know. So just a few housekeeping items. My name is Linda Deck, and I'm with the Minnesota Department of Health WIC program, and I also do many things with the Minnesota Breastfeeding Coalition. This webinar is being recorded, so just so you know. We ask that you put your audio on mute right now, and but not on hold, because if you put us on hold, we will hear music or that kind of thing, and there's really not a way to override that. So mute or *6 on your phone would be helpful. If you have questions, you can use the chat box to enter those, or at the end, unmute yourself, and then over the phone line, you can also ask questions. All right, we will get going. At this point, I'd like to introduce Dr. Pam Heggie. She is a pediatrician at Central Pediatrics in St. Paul, and she will finish her own introduction. Thank you.
I would bring it up again. Thank you, Linda. Hello, everyone. I guess the rest of my introduction is that I'm both a pediatrician and lactation consultant, and I have experience with Baby Friendly because I'm one of the lead physicians for the University of Minnesota when the university worked on Baby Friendly designation in 2010 to 2012. And I'm also part of the Minnesota Breastfeeding Coalition. So I'm happy to talk today about some updates from the World Health Organization about Baby Friendly Hospital Initiative. And I have no disclosures to report.
Excuse me, everybody. We can hear some background noise, and that's going to be recorded. If you could put your phones on mute or your audio on mute, that would be helpful. Thank you.
I'm just going to quickly review the objectives for the talk today. What I plan to do is start by reviewing the history and current status of the Baby Friendly Hospital Initiative, both in Minnesota and nationally and globally, and talk in particular about the changes that the World Health Organization and UNICEF have made to the 10 steps to successful breastfeeding recently in April of 2018. And I'll discuss the reasons behind the changes and their impact on breastfeeding support and newborn care in Minnesota hospitals and throughout the country. First, I wanted to talk about some terminology, just to be clear about which organizations we're talking about as I go forward. Most folks are familiar with these acronyms, but I just wanted to review. The World Health Organization is an organization in Geneva, Switzerland that puts together global health guidelines and policy about many different health topics. And they're the ones, along with UNICEF, the United States Children's Fund, that started the Baby Friendly Hospital Initiative in 1991. So it's often abbreviated BFHI. And it includes the 10 steps to successful breastfeeding, otherwise 10 steps. And the last acronym is BF USA, Baby Friendly USA. And those hospitals, folks that have been involved with the Baby Friendly designation will know of Baby Friendly USA, which is the accrediting body for Baby Friendly designation in the United States. And before I go into the changes that are going to be happening and are outlined in the April document from World Health Organization, I just want to reassure folks that have been involved with Baby Friendly, either are working in a Baby Friendly hospital or are working on 4D designation and are working towards becoming Baby Friendly, that these changes will not be implemented in the United States for at least 2 years. So Baby Friendly USA has assured everyone that we're going to continue with the current guidelines, but work towards implementing these changes that I'm going to talk about 2 years plus. So it gives people time to get used to the changes and to plan for them, but I think it's helpful to hear where Baby Friendly USA is coming from, where World Health Organization is coming from, and what the changes are and why. So to start with, I just want to review the Baby Friendly Hospital Initiative, a little bit about its history. And I realize that folks that are listening to the webinar, some of you may know this in detail because you've been doing Baby Friendly or you've been through the designation, but others may be interested in just beginning. So I want to just do a quick overview. That the Baby Friendly Hospital Initiative was developed by UNICEF and WHO in 1991, and really it was an attempt to reduce infant mortality by increasing breastfeeding rates worldwide. Because in the 1970s and 80s was when we were at the lowest for breastfeeding rates throughout the world, 20% in the 70s, 30% in the 80s, and that was any breastfeeding. So the thought was to do something that would help hospitals promote breastfeeding and support breastfeeding throughout the world. And they picked the name Baby Friendly because the name, the words baby and friend have similar meanings in all languages, so it was easily translatable across the world. And it's considered an international award for birth hospitals that are implementing best practice maternity care, which the best practice is the 10 steps to successful breastfeeding. And the 10 steps are considered hospital practices that are known to improve breastfeeding rates, and they're very carefully researched and updated over time, and based on evidence in the research literature about steps that help with supporting breastfeeding in the hospital and help to improve breastfeeding rates. And the Baby Friendly Hospital Initiative involves a certification process that includes an on-site visit to document the compliance. So you can say that you're doing it, but you also have to prove that you're doing the 10 steps by a site visit. And it also requires compliance with the International Code of Marketing of Breast Milk Substitutes, which has a couple of components. Basically, making sure that hospitals pay for formula and for supplies like any other medical supplies, and that there are no free donations of formula or feeding supplies or discharged diaper bags with formula or coupons to families, and not sponsoring educational sessions by the formula companies. So that's essentially the overview of the Baby Friendly Hospital Initiative. And a little bit about some statistics, both globally and locally. Internationally, there are about 20,000 hospitals in 152 countries worldwide, so almost every country in the world. But unfortunately, it's still a small number of babies that are actually covered by baby-friendly hospitals. In 2017, the World Health Organization estimated that only about 10% of babies are born in baby-friendly hospitals, and they're really wanting to change that and have that be more of a universal coverage. Now in the U.S., the statistic is 25%, but that doesn't mean 25% of babies born in baby-friendly hospitals. The statistics from Baby Friendly USA is 25% of U.S. birth hospitals are baby-friendly, so it's the hospital number. And it's really increased quite a bit. In 2007, we only had almost 3% of hospitals in the United States baby-friendly, and now just recently surpassed 500, and it's 524 in all 50 states, including Washington, D.C. and Puerto Rico. So it's a huge change. Thanks to a number of initiatives from the CDC grants, learning collaboratives that some of you may have participated in, the Best Fed Beginnings, the Empower program, and some other programs as well. So it's really accelerated things, and yet we still have a long way to go. So in Minnesota, we've also had an incredible change over the last 10 years. So right now, the statistics in Minnesota, as of just a few weeks ago, 14 baby-friendly hospitals out of about 94 birth hospitals. The birth hospitals in Minnesota tend to change from time to time because of hospitals changing their maternity care practice and what hospitals are offering maternity care and which aren't. But it's approximately this. And so we have 14 baby-friendly hospitals, which comes out to about 15% of birth hospitals in Minnesota. But if you add up the number of births at all of those different hospitals, about representing 30% of births in Minnesota. And historically, before 2010, we didn't have any baby-friendly hospitals in Minnesota. And Austin Medical Center was the first in 2010. And now we're up to 14, which is exciting, and we still have a long way to go. One of the things that happened in 2014, there was a call to action by the Commissioner of Health, Dr. Ellinger at the time, really encouraging not entirely baby-friendly, I mean, baby-friendly if people wanted to get designated, but really encouraging all hospitals to do the 10 steps, that the 10 steps were the best practice to be striving for. And that led to MDH, the Minnesota Department of Health, creating Best Breastfeeding Friendly Maternity Centers 5-star designation award program, which again encourages hospitals to work on one step at a time, and with each star representing 2 steps, so that when you get to the 10 steps, you get the 5 stars, and you can get on the MDH website and get your hospital recognized. So some efforts in Minnesota to try to accelerate the baby-friendly hospital initiative. And here's a list of the 14 baby-friendly hospitals, really exciting to see. And we've had our first redesignated hospital just recently, the University of Minnesota. After 5 years, the hospitals have to be redesignated and go through the process of the site visit again, and the U did that. So another thing about baby-friendly, and whenever I talk about baby-friendly, I would like to go back to some of the basics, which I know many of you know, but I think it's really helpful for all of us to reflect on why are we talking about baby-friendly. And it's really to reflect for ourselves, but also when we're talking with others about why is baby-friendly important. And it's because breastfeeding matters, that it matters to babies and children and mothers and families and environment and economically. And that it improves, breastfeeding improves health for babies and children, less infection and obesity and diabetes and SIDS, and improves health of mothers. Families have less time off of work for sick kids and save money, and in general, kids and families are healthier when mothers are breastfeeding and they're getting supported. Environmentally, breastfeeding is really important, and it matters because of a green, low carbon footprint, less pollution, and just in general, a natural, sustainable source of nutrition, which a lot of folks talk about now just with nutrition in general. And if we're talking about healthy infant nutrition, breastfeeding is a sustainable source. And economically, it saves money for families and the healthcare system and adds money to the global economy. So again, putting it in perspective, why are we doing this? And a couple of other reasons to emphasize why baby-friendly hospital initiative is important. Some of these on here: market share, prestige with designation, improved patient satisfaction, patient-centered and family care, family-centered care, and has led to a lot of the successes that we talk about with baby-friendly. And I'm going to review some of the successes that have come from the World Health Organization assessment of where baby-friendly is right now, and then review some of the challenges and that have led to the revisions that I'm going to talk about soon. So the baby-friendly successes, we have 14 baby-friendly hospitals in Minnesota. We're increasing our breastfeeding rates both in Minnesota and throughout the country, and baby-friendly consistently increases short and long-term breastfeeding rates by about 30%. So it has a huge impact on breastfeeding rates, and it's widespread implementation. It reduces racial disparity in breastfeeding rates, and it's transformative. Many hospitals who have been through the process of going baby-friendly have talked about how it's really transformed both themselves individually as well as the environment, changed the environment and attitude about infant feeding, more patient-centered care, staff attitudes have changed dramatically, skill levels have really improved, and families report getting a lot more support for breastfeeding. Formula use has dropped and has become more appropriate and when it's medically indicated, and patient satisfaction improved. And just overall quality of care for breastfeeding support has been dramatically increased with the baby-friendly implementation. But then there's also been a lot of challenges that both the hospitals that have gone baby-friendly report and others as well, policymakers, and the WHO has looked at all of these factors and taken that into account to lead to the changes. So one is that it's voluntary, and baby-friendly takes a lot of energy and time to get things going, often involves passionate folks who do a lot of persuasion of administration, leaders to get things going, and a lot of excitement goes with that. But it being voluntary also for hospitals implies something that's concerning to WHO, and that is that with it being voluntary, it implies that not doing the 10 steps is somehow the norm, or that that's standard of care. And that that baby-friendly hospital initiative is like icing on the cake and is just something extra. And I think what the World Health Organization wants to change is to have the 10 steps be the standard of care, and that if they're not doing this 10 steps and not baby-friendly, that that's somehow different than the norm. And other challenges, just to go through quickly, funding limitations, competing priorities. There are a lot of things that the hospitals are trying to do with electronic record and other technology. It depends on champions to start and lead, and so that's great when people are really excited about it, but sometimes it's a lot for a few champions to carry forward, and if champions leave or change, it's sometimes not sustainable. And there's a lot of resistance. Many research studies and surveys have shown that physicians are often resistant, nursing staff too, and that's hard sometimes when people are fighting an uphill battle to break through resistance, and it can be discouraging. There's training is very intense, which is important to do, but it really requires finances, training, getting people recruited to do training. Sometimes staff have to leave their regular shifts in order to get trained, and sometimes the hours that have been required don't necessarily translate to skill competency. The assessment and reassessment is expensive, and the emphasis on designation is not always leading to systems change. It's sometimes like teaching for the test, and then there's designation, and everyone is excited and cuts the cake and cuts the ribbon, and everything's great, but it sometimes then, if it's not hardwired into the system, it will quickly sometimes revert back to what we've always done, and unless it's systemic change, it's hard. Designation doesn't always help. It's hard to sustain the changes, and often there's lack of compliance with codes. It's very hard to resist sometimes when hospitals get free stuff like free formula, and then it is a requirement that they have to pay for it. So moving on to some of the changes. So just to outline some of the changes that are happening with the 10 steps. So it's reorganized into 4 management procedures and 8 key clinical practices, which I'll get into. And I know that equals 12, but it actually is still going to be the 10 steps. And the 4 management procedures are actually combined into step 1 and step 2. So one of them has 3 components. So actually it will continue to be the 10 steps. And basically the changes have wording that's changed, but the themes and the content, the core content of the Baby Friendly Hospital Initiative 10 steps are the same. Another really big thing that's changed is the International Code of Marketing of Breast Milk Substitutes is now included in one of the 10 steps in step number 1, which is huge because in the past it's always been kind of a footnote. It's definitely a part of Baby Friendly, but it's not always been incorporated, and it's sometimes glossed over and not paid attention to until the time of site visit. Data collection and monitoring, quality improvement, process is important, and that's important for sustainability. The other really big change is that the new guidelines are allowing the use of bottles, nipples, and pacifiers. It's really emphasizing having counseling about bottles, nipples, and pacifiers, but not prohibiting them. And that's probably one of the biggest changes, and I'll talk a little bit later about some of the research that led to that. But it's really creating informed choice and reducing some staff and family resistance, which sometimes there was so much dancing around trying to not use pacifiers or find pacifiers on the black market, so to speak, hidden in some cabinets down the hall, that people were spending more time not doing things and not spending as much time supporting breastfeeding. So the hope is that that will remove some of the barriers. The on-demand feeding has changed. There's more practical advice about and guidance and support emphasized. Staff training is more competency-based and not set in curriculum or number of hours. And post-discharge care, step 10, it really emphasizes continuity of breastfeeding care and not just support groups. But the support groups are really important, but it's a both and to emphasize continuity of lactation care after discharge. So a little bit about why the change, what drove this. And mainly it's everyone's experience over 25 years, because in 2016 was when there was the 25th anniversary of the Baby Friendly Hospital Initiative. So the World Health Organization, in anticipation of the anniversary of Baby Friendly, went to develop some systematic review teams. And the World Health Organization has strict protocols about how they do guideline review. And they set up these review teams looking at databases like the Cochrane database of systematic reviews that looks at evidence-based research for various topics in lots of areas of medicine, but that's one of, and there's other systematic reviews that also were looked at. So then that led to what WHO called the Baby Friendly Hospital Initiative Congress that met in 2016 with 300 plus global healthcare leaders. So they invited folks from 133 countries, leaders that were involved in Baby Friendly in some way, and they set, they had people work together to look at the current status of Baby Friendly, basically looking at the successes, the challenges, the evidence, and leading to 2 documents that got created. And it's a little bit confusing about these documents, but I've taken pictures of them here and included them. One is the 2017 guideline and one is 2018. And the 2017 guideline that says guideline on the top is all about the evidence for the 10 steps. I mean, many, many pages and pretty much everything you wanted to know about all the 10 steps. And I'm not going to review all of those here because that's another talk. But just to know that there was a huge review of the evidence, and that led to the 2018 implementation guidance, which is the new Baby Friendly Hospital Initiative Revision. It was kind of confusing when there were these 2 different documents, but that's what's out there. And one of the systematic reviews came from the Yale School of Public Health, and it was printed in the journal Maternal and Child Nutrition, the Impact of Baby Friendly Hospital Initiative on Breastfeeding and Child Health Outcomes. And basically they took 58 studies and they looked at the 10 steps, and they found that there was a very clear positive impact on short-term, medium-term, and long-term breastfeeding outcomes, and really clear that Baby Friendly had the 10 steps made a big difference in terms of breastfeeding rates, and that there was no negative impact from the Baby Friendly. So from that systematic review, a couple of key messages that then led to, and it was included in the WHO changes, that the 10 steps should be considered a quality improvement system, that really it's a package of steps and actions to support breastfeeding, not just one step at a time, and that there's a dose-response result. The more steps, the better the breastfeeding outcome, and thinking about them together as a whole. And they emphasized a couple of steps, step 10, step 6, and step 2, as being some of the most important, but all of them together are important. But community support, avoiding hospital supplementation, and then really important, the 10 steps implementation, relying on having really well-qualified staff. And so the baby-friendly revision, so what I talked about before were the 10 steps and what was revised. And this is sort of more of how the baby-friendly designation and the baby-friendly infrastructure works. And this is a summary of some of those changes. So number one is the external assessment, so that's the on-site designation, will really be simplified and focus on technical assistance and not as much on designation, not as much of teaching for the test, so to speak, but really ongoing technical assistance and support and help and not reinventing the wheel. And that's for United States, the Baby Friendly USA. And there'll be more internal monitoring, which they found the more you collect data and each individual hospital reports what's going on, the more effective the sustainability is, that rather than an external assessment. So integrating and wiring into quality improvement within the health system, not siloing out baby-friendly, but have it integrated in other initiatives that are happening in mother-baby care. And designation not really being the be-all and end-all, that it's really an incentive, yes, and it's a good thing to get to, but often it depends on competition to drive the initiation and the maintenance. And it's very high cost, both to run a program and for the hospitals to invite and to have the designation, and there's a lot of administrative costs with that. So if it can be simplified and still be effective and have good quality, it will be helpful. So they're planning to continue the designation for the most part where it's working, and if it's not working, to change that, and to really look at different incentives other than designation. So there's some different ideas out there about what are the incentives. One is pay for performance. Hospitals love to get paid, like we all do, and paying hospitals for doing the 10 steps is potentially an effective incentive, paying more and better reimbursement for hospitals doing the 10 steps and less for hospitals that aren't doing the 10 steps. Other possible incentives would be mandates, like a legal mandate. In California now, there's legislation that requires hospitals to comply with the 10 steps. No, to my knowledge, not in, any other states have that legal mandate, but it may be coming. Another possibility is maybe joint commission or something like that, tying incentives to hospital accreditation. And another possibility is state health departments, maybe something with licensing, with quality of care, some standard of care that's an expectation rather than it being the norm to not do the 10 steps. So that's some of the things that they're looking at in terms of the WHO changes. So this is a review of the 10 steps, and for the remainder of the time after this, I'm going to go through each step and tell you about what was the old step and what's the new step, and kind of unpack the steps as we go through. So just, again, as I mentioned before, there's 4 critical management procedures is what they're calling them, but really only 2 steps. So the first 2 steps are facility policies, sort of what's the scaffolding for creating an infrastructure to allow the clinical practices to happen in the facility. So that A, B, and C is under step 1. And then there's number 2 of the staff training, competency-based, and then the list as I'll go through in a few minutes. Again, the folks who know the 10 steps and are familiar with them will notice that they're very similar in terms of the topic, but the wording was very carefully chosen, and you'll see in a minute how important even one word is in terms of the changes that they made to the 10 steps. So I'll start with step 1. And again, this is the scaffolding for facility policies. And the former step one, so basically all these slides that I have will say the new and then the old, and I'll kind of go through this quickly so that we try to have some time at the end for questions. But the old one was have a written infant feeding policy that's routinely communicated to all healthcare staff. And it's changed now to really include 3 different things. So the A is that the code is completely integrated, which I think is really important, encouraging hospitals to pay for fair market value for the formula, to not have free stuff to give out to families, to really do marketing for health and not marketing for formula, and to pay for the formula and bottle supplies like any other medical supply at the hospital. Having a written infant feeding policy, and that's pretty standard, but the change is that it says routinely communicated to staff and parents. So really important that we want to be letting families know what is this baby-friendly thing, what are the 10 steps, and including parents and families in that as well, and making it readable and understandable. And pretty much that policy drives practice. And if a hospital has a policy, that's often the first thing that people go to look for consistency of care, similar messages, and evidence-based policy. So that a lot of hospitals that start out on baby-friendly pathways start with developing an infant feeding policy, which also is not a breastfeeding policy. It includes both breastfeeding and formula-fed babies. It's all babies, and it's all about infant feeding. And then the last here in step 1 is the establishing ongoing monitoring and data management, which pretty much is the quality improvement idea that find something to measure and follow it, but not make it too complicated. More is not better. Less is more. Find maybe 2 or 3 things like rate of rooming in or discharge exit interviews with families about their experience, or something that you can track over time, the time to first breastfeeding, what was, how many babies fed within the first hour, that kind of thing, and that data management drives change and also helps with sustainability. So the next is step 2, the staff competency, really ensuring that staff have sufficient knowledge and competence and skills to support breastfeeding. And the difference is that it's different than training all healthcare staff in the skills. And certainly training is important, but what they're recognizing is that many staff come to the hospital with lots of experience, and it doesn't make sense for them to go through a 20-hour training when they have the experience and they have the skills. And others come with very little experience, and sometimes because there isn't very much curriculum in medical schools and nursing schools, there's a lot of catching up to do in terms of breastfeeding competence. So it's really that ensuring the skills and competency-based skill assessment rather than just send everyone to a class, and sometimes the 20 hours aren't really as effective as maybe a shorter amount of time, but more effective with skill stations and that kind of thing. And I know a lot of the hospitals in Minnesota have been taking the lead on that, where there have been a lot of skill stations and programs developed that hospitals have been sharing with one another, and I think that's the kind of feedback that WHO has been getting in terms of changing the staff competency type of model. But it's definitely, you've got to have trained staff in order to do a good job for good breastfeeding support. And then there's prenatal education, very well studied that it's huge impact on breastfeeding success, and that their WHO in their document, their evidence-based document, named 18 qualitative studies that looked at what mothers and families want out of prenatal education, and there's a clear sense that they're not getting as much information about breastfeeding prenatally as they want to, that they want more discussion, and so that's the change from informing to discussing the importance and management of breastfeeding with pregnant women and their families. So really discussing and the emphasis on throughout the prenatal period, not just one time or right at the first prenatal visit or the last prenatal visit, but that it's a education throughout pregnancy. And one of the things with the Minnesota Breastfeeding Coalition, we put together a toolkit that can be downloaded at this website, and going to the prenatal toolkit area, and it's free for anyone who wants to use it, and many people have printed it out and put it in the clinics and used it as ongoing prenatal education dialogue, and really goes through, this is a table of contents, and I'm just going to show you some examples from that toolkit, but many hospitals have found it very helpful to go through different topics at different times throughout pregnancy and prenatal care, and it really addresses some of the concerns that have come up in the research about what moms and families want to know, and actually helps with breastfeeding success long term. The more folks know before delivery, the better. So there's an example, another example of why breastfeeding is important. That's another page from the toolkit. So going on to step 4, skin-to-skin and breastfeeding initiation. One of the old step 4 was help mothers initiate breastfeeding within 1 hour of birth, and skin-to-skin was part of that, but not, it was sort of embedded in what you do in step 4. And now it's really clear, the research has shown that facilitating immediate and in particular uninterrupted skin-to-skin contact is really important, because that's a way to get babies ready to breastfeed. And in the past, it used to be when we didn't know as much about the stages that babies go through getting ready to breastfeed, it would be sort of the idea of quickly getting baby to breastfeed, documenting, trying to get initiation to happen quickly, which we want before the first hour of birth, because we know that early initiation actually improves breastfeeding rates and improves milk supply. But if you are in too much of a hurry, then you get ahead of the baby, and it gets in the way of baby's neuroprogramming in leading up to being able to latch on and to breastfeed effectively. So there's 9 stages after birth leading to successful breastfeeding, the idea that don't interrupt the baby. You don't need to hurry up, and that skin-to-skin content and the 9 instinctive stages after birth that are clearly outlined in research studies, that we need to give babies time to do all of these pre-rooting behaviors and so forth, getting ready to breastfeed, and that's just as important as the initiation of breastfeeding in the first hour. So that's kind of the change in step 4, and clearly evidence-based, and a little bit of a change linking them together, and this is another page from our Minnesota Breastfeeding Coalition prenatal toolkit. So step 5, breastfeeding support for mothers. So the new one is it's very similar, but again, the wording was changed very carefully, so that it says now, support mothers to initiate and maintain breastfeeding and manage common difficulties. Different than just showing mothers how to breastfeed and how to maintain lactation, even if separated. It's basically going beyond that to, number 1, to support mothers, and support involves many different things, both teaching about latch and position, motivation, emotional support, and also helping to empower mothers to manage common difficulties themselves. So another thing from the toolkit, we have a couple of things about latch, baby's first feeding. It's all about empowering mothers as part of the support to problem solve themselves, laid back breastfeeding positions, some different, helping babies latch in different positions, and then problem solving. What happens when there's engorgement, helping milk to flow, helping empower mothers so that when they go home after 2 days and engorgement happens at 4 days, that they're ready to manage that. And that's really the emphasis in that change to this step, and a little bit about hand expression. So in step 5, again, it's supporting, and the evidence is really clear that support and trained lactation support makes a huge difference, particularly in the first 6 months post-delivery, not only in the newborn period, but afterwards, and clearly evidence-based that trained support helps. So step 6, supplementation. Hasn't changed a lot, although it's a little stronger. They do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. It's very similar, but again, it's really clear with the evidence that supplementation that's not medically indicated and without expression of milk to stimulate prolactin decreases milk supply. And there's a research study that they quote in the WHO evidence that says that if a baby is supplemented before discharge, that baby is 2 times likely to not be breastfeeding at 6 weeks of age. So it's a huge impact. And one of the things that they're also talking about is supplementation, what to supplement with. And there's a clear sort of order of preference, again, medically indicated, which there's clear criteria for, and from WHO and Academy of Breastfeeding Medicine, which is ABM, that mother's milk, expressed milk, pasteurized human milk, the milk bank from, donor milk from milk bank, and you'll hear more about that in the next webinar. Hypoallergenic formula, protein hydrolysate type, and cow's milk-based protein, or cow's milk-based formula, sort of the different potential supplementation options. And again, from the toolkit, a little bit about pasteurized human milk, and a bit, a diagram and a form that addresses a common concern about how do I know my baby is getting enough milk, and talking a little bit about what tells you baby is getting enough milk, what does not tell you about how your milk supply, and educating about wet diapers and the soiled diapers and what that says about milk supply, which often helps to keep babies from getting inappropriate supplementation. Step 7, rooming in. Again, very similar about practice rooming in 24 hours a day, but again, a really big wording change, and that is that enable mothers and their infants to remain together and practice rooming in 24 hours a day. Really different than just practice it, because WHO is really emphasizing enabling, creating an enabling environment. And really it's that not even just allowing, it's really enabling and encouraging and making it happen so that it sort of becomes what we do. And one of the things we emphasize in the Minnesota Breastfeeding Coalition toolkit is that not to call it rooming in necessarily, but that's what WHO calls it, but the family room, keeping baby near, because sometimes rooming in can be interpreted as the baby's rooming into the mother's room like an invasion, and if you see it differently as a family room, everyone's staying together, it's sometimes seen more positively, but it really makes a difference in terms of helping moms and babies stay together, moms reading babies' feeding cues, and some ways to enable, and I'll go through quickly, but this is what they outlined in WHO and what others have done that we've heard about at different conferences here in Minnesota, that physicians do the exams, the baby exams in the patient rooms, having a tool bucket to go around for that, family-centered care, keeping baby near, that the idea that the doctors and nurses provide care at the bedside, not taking the baby away, pair care or couplet care, and it really boosts family confidence that they really know how to take care of the baby when they go home. Another thing that has helped is rooming in, changing the time of waits, not having midnight waits and waits done in the room in the evening shift, and allowing discussion with families about the wait and improving parent confidence as well. Changing the name of the nursery and getting rid of nursery completely, again, enabling rooming in to happen. So some places like University of Minnesota calling it the Newborn Medical Observation Unit, so that it's a place your baby doesn't want to go to. It's the newborn nursery in the past, and now it's more for when the baby needs to be observed more carefully. But for the most part, the standard of care is rooming in. So that's rooming in, and we've got a couple more steps to go to, and then get to some questions. But step 8 is responsive feeding. So the big change there is that it was encouraged breastfeeding on demand, and the on-demand terminology was troublesome for a lot of folks. It had good intentions, that it was cue-based feeding and responsive feeding, and it was trying to get away from the scheduled feeding of the past, where babies would only be fed every 3 hours, and they'd all come down the hall in their bassinets and get fed and go back to the nursery. But it was interpreted in many different ways, and not always that helpful in terms of really supporting mothers to do what they needed to do, like be responsive in feeding. So they changed it to support mothers to recognize and respond to their infants' cues for feeding. So it's really looking at helping, this is why rooming in is so important, helping mothers and families recognize when a baby's ready to eat way before baby's crying and past the time of being able to latch effectively and easily. So again, we have in the toolkit feeding on cue, feeding signs, mouth movements, sticking tongue out, rooting, some of those things, but really that sense of responsive feeding and important. And then this one I'm going to spend a little bit more time on because this is probably the most surprising and controversial and probably, in my opinion, good change that is coming about with the changes in the 10 steps. And so it's about bottles and pacifiers. And so it's counsel mothers on the use and risks of feeding bottles, nipples, and pacifiers. And that's changed from give no artificial nipples or pacifiers to breastfeeding infants. So it's really changing to be counseling about the use and potential risks of bottles and nipples and pacifiers and their impact on breastfeeding, but it's not prohibition. It's not saying no, never. And this is what I decided to do, is to take some phrases directly from the WHO evidence review and to give you a sense of the terminology and how they're putting this together. So basically, this is a quote from the 2017 evidence-based guideline. Avoidance of pacifiers or feeding bottles and teats, which is the European way of terminology for nipples. So avoidance of pacifiers or feeding bottles and nipples during the stay in the facilities providing maternity and newborn services in the first 5 days of life make little or no difference to the rates of any breastfeeding among term infants at discharge and any or exclusive breastfeeding outcomes at 3 or 6 months. So this was looking at the evidence, and many folks who do, I know that for me as a lactation consultant, and I have seen a negative effect of bottles and pacifiers, what people call nipple confusion or flow confusion. The physiology of sucking on bottles and pacifiers is different than the physiology of breastfeeding, and the flow is way different. But we emphasize a lot now, paced bottle feeding, trying to not do pacifiers for a few weeks, but do finger sucking. But the reality is that many times the pacifier or the bottle prohibition has been one of the reasons that people don't want to do baby-friendly at their hospital. And it's become such a barrier that WHO has decided that they would, given the evidence, and this is a strong evidence from this study, these two studies, that these are systematic reviews about bottles and pacifiers. And the first one is the effective restricted pacifier use in breastfeeding term infants for increasing duration of breastfeeding. So these are term infants, not premature babies. But that's from the Cochrane database. And the second one was from Britain, avoidance of bottles and artificial teats or nipples and the effect on breastfeeding. And that was a different, Prospero is a similar one, systematic review like the Cochrane database. And both of them came up with the final report, like I just had read, that there was no difference in the rates of any breastfeeding among term infants at discharge and exclusive breastfeeding outcomes. Now, some people say, well, maybe there's gaps in the research, that maybe we need better research and that actually there is an impact. But the most important thing is that what we're talking about is counseling and talking with families about the impact and recognizing that these quotes are really important. that many mothers, this is another quote from the qualitative research that they did, interviewing families about bottles and pacifiers, that many mothers value pacifiers, that a considerable number would introduce pacifiers even when discouraged to do so, and they value the convenience of using bottles and nipples to provide breast milk when their infants are not at the breast. Mothers can be supported to make informed decisions regarding the use of pacifiers and bottles and nipples during the hospital stay and after, and then ensure that they're aware of the slight risk of interfering with breastfeeding during these early days. So it's really a radical change, but it's trying to get at the resistance that's out there and allowing the pacifiers and bottles, but it's a dance because they also emphasize this: remember the code. So it's kind of a both and. They say, remember the code. There should be no promotion of breast milk substitutes, feeding bottles, cheats, pacifiers, or dummies, which are dummies are pacifiers in Britain or Europe. So you shouldn't be promoting them, but don't prohibit them either. And it's basically like in all of medicine, we should have shared decision making. What are the pros and cons? What are the needs? And then how do you avoid the problems that might arise, as we know, trying to decrease how many minutes the baby's sucking on the pacifier, maybe after feeding the pacifier, trying to hold off for a few weeks, trying to do pacing of the bottle feeding so that the flow is more like breastfeeding rather than a constant flow, and all of that can help, and really emphasizing helping moms with breastfeeding rather than prohibiting some things that gets in the way of our energy going towards breastfeeding support rather than locking up the pacifiers. So step 10 is all again about breastfeeding support. And the difference is that in the old, step 10 is fostering the establishment of breastfeeding support groups and refer mothers to them on discharge. Really great, really important, and that's helped a lot of support groups and mother-baby groups in La Leche League and many, many connections with other moms, Baby Cafe, all of that really important, but it's not the only thing. And what's been missing is the coordinated discharge. So the new is coordinated discharge so that parents and their infants have timely access to ongoing support and care. So really what that is coordination of care. Who's going to see the baby for follow-up, not just in the pediatrician or family practice office, but who's going to see them for breastfeeding support before problems happen so that they can be followed closely, and trying to coordinate that. And that's a big change and still a big need and a gap. So the final, to finish in the next few slides, and then we'll have a few minutes for questions, is something that I put together just in general. What is baby-friendly? What it is and what it's not. And this is pretty much consistent with the philosophy that WHO has, and I think the new revision is reflecting some of these ideas, and that is that what it is that families receive consistent and accurate information about breastfeeding and about infant feeding choices so that they can make informed choices about the health of their babies and of themselves. And best practice maternity care, but again emphasizing that it's the 10 steps are standard of care. It's not the norm to not do the 10 steps, that it's really flipping that around, and that the 10 steps are based on research and that they're all evidence-based. It's really carefully done. It's not anecdotal. And that there are some gaps in the evidence, but that we can do better at doing some more research to support what we need to be doing. And that it's a package of care, not random steps, and quality improvement process. The PDSA, which a lot of people have done, the Baby Friendly Hospital Initiative or other quality improvement projects, it fits right into that plan, the P, plan, do, study, act, and you're constantly measuring and then establishing a protocol, testing it out, and changing it to have better quality improvement. What it's not forcing mothers to breastfeed. It's honoring feeding choice. It's helping moms and families reach their infant feeding goals. It's not making families pay for formula. Some people think that when they hear about the code, but it's that hospitals pay for the formula and pay for supplies just like they do with antibiotics and other medical supplies. It's not leaving mothers alone and exhausted. Rather, it's family-centered care at the bedside to help mother rest and learn about her baby and increase her confidence and increase the family's confidence. And it's not just for breastfeeding families, it includes all families. And that it takes a village to go baby-friendly. I want to honor all of the hospitals that have, in Minnesota and elsewhere, who have become baby-friendly designated, and those who are on the journey, and those who are considering it, and everyone in between, and even pre-considering. It's all important to be part of the village as we go forward with baby-friendly. And that the baby-friendly hospital initiative is baby-friendly, mother-friendly, family-friendly, and helping all families reach their infant feeding goals. And again, with WHO's goal overall is that it'll be universal baby-friendly hospital initiative, that it's universal 10 steps, and that becomes the standard of care and the norm for all babies in hospitals throughout the world. So we can take some questions now.
All right. To unmute your phone, press #6 for those who have don't have that mute button on their phone, or you can enter them into the chat box in the webinar, and we will take questions that way. In the meantime, what I'd like to do is do some final details. No, hit the next slide down. Yeah, post-webinar details. For attendees, you will receive an email with a SurveyMonkey link, and that will take you to post-test and evaluation as required for continuing education credits. You will also be sent the certificate of attendance, which will have the CERPs and contact hours for nurses. For those who are would like CMEs and indicated that during registration, you'll receive a form to complete and to return to North Memorial, which is the provider of the CME credits for this webinar. So thanks to Dr. Heggie and for doing this presentation, and to North Memorial for partnering with us in providing the CME credits. So if there are any questions, please go ahead and submit that, and we'll wait a little bit to see if any come in. Did you have a question?
Dr. Heggie, I did have a question. Thank you for the excellent presentation. For hospitals that have already received baby-friendly designation, and we have the posters with the 10 steps up on the wall, when would, you said by 2000, or when would we expect to change them? Are we going to need to change these posters, and when do we start implementation of the changes?
Well, what I've heard from Baby Friendly USA, so the accrediting organization for the U.S., is that at least 2 years and maybe more than that. So that right now, it's the same 10 steps that we've already been doing, so you don't have to change your posters.
Right.
But Baby Friendly is going to be working on creating documents that can be used. Probably they'll have a poster that will be used to replace the one that's there now. And you have plenty of time. So keep doing what you're doing. Good question. Okay.
Dr. Heggie.
What would be done in Minnesota to encourage baby-friendly hospital initiative? So can I just talk and say, okay. Well, great question. I think it goes back to the incentives that I outlined as possibilities. And I think for Minnesota, one would be having pay-for-performance payment for hospitals. I think that would really give us the most bang for our buck, because I think that's better than mandates where you have sort of a joint commission type assessment and people get nervous about that, and it's not as positive an incentive, but if you have a payment incentive where you get 2% more reimbursement, for instance, for having maternity care that implements all the 10 steps and is baby-friendly, hospitals may really jump at that because it's a time of really, you know, tight finances. So I think if the sky were the limit, that would be my recommendation.
And I think we have time for just one more question. We heard somebody on the phone.
Yeah, Dr. Heggie, do you foresee baby-friendly establishing guidelines for that annual QI, or will that be internal, each organization determination?
I think initially it'll be Baby-Friendly USA doing that, but I actually would encourage both and, because every hospital has their own issue that might be a challenge. Like some hospitals talk about rooming in was really easy to do, and other hospitals say rooming in is really a challenge, and they might want to do a QI internally because that's their issue. Others had other issues that they might look at, and that might change from year to year. But there'll be some standard things that Baby-Friendly USA will give for hospitals to be looking at. And again, it's the idea that it's not make it too complicated. Do something that you're actually measuring well, and then look at it every month and give feedback to your staff and to your leadership and see positive change.
Good point. Thank you.
All right. We are at the end of our webinar time. We will address any other questions that come in by email. So thank you for attending, and for those attending the second webinar, you received a second link for that to log back in at 10 o'clock. So otherwise, thank you very much, and hopefully you'll see more of this from us again at another time. Bye-bye.